All right. Good morning, everybody. Tim Kubrick with Labor Relations, and thank you for being here. I just think we'll start with some introductions, so start.
Caitlin Shaw, Admin Assistant, Labor Relations.
Heather Frederick, Chief Financial Officer.
Nancy Bolton, Director, Risk Management and Benefits.
Pat Kalb, the Staff Association.
Alexander Lopez, PBA.
Justin Katz, CTA.
Leo Harris, CTA.
Joseph Brenner, SEIU.
Sorry, guys.
All right. Again, thank you all for being here today. So I know it says it's negotiations in the invite, but really this is pre-negotiations. We just want to give you an update of some things as it relates to benefits before we get into our actual negotiations. So we'll get started with that. Nancy has a presentation to share, and then we'll open it up for some questions and try to establish our next dates that will come together and review maybe some proposed changes and get into negotiations. All right. Nancy?
All right, should we dive in? All right, everyone. Just a little bit of introduction. I don't know that I've met all of you. I've met some of you. I am new to the district. This week is my 4th month. It's been great. Looking forward to getting to know all of you better. But I have been in the benefits space on the management side of the table for 25 years. So I know I look like I'm 25, but in fact I'm not. So just so you know, I've worked with a lot of the same players. I'm familiar with United and their plans, and our plan actuary here through Gallagher Benefits is actually the same actuary that I've worked with many years. He's very well respected in the field, and so I'm confident that the numbers that I'm going to present to you are at least calculated by a qualified actuary with an alphabet after his name. So we're going to dive in. Unfortunately, we're meeting on terms that aren't ideal. I don't have great news to share with you, but I believe in transparency and facts, and so let's jump in, and I'm just going to 7 slides. We're going to overview where we are right now with the benefits plans. So we'll cover in this brief presentation just an overview of the plan coverages offered in your articles. They're very specifically noted. Many of the plans, life, dental, vision, some of our voluntary programs are offered under a cafeteria plan, Section 125, as allowed by the IRS, tax favored where allowed. But the primary conversation today is going to be about the health plan, the actual $200 million self-insured health plan. We'll touch on the current monthly premium rates paid by the district and employees, and monthly consumer-driven health plan district contributions, the fund balance, performance to date, and cost and expenses, plan years 20 to 24 as projected by the actuary, and preliminary considerations for collaborative plan changes. So some of the premium, just health premium highlights. The upcoming 2022 benefit year, which is no longer upcoming, it's actually we're 4 months in, will mark the 9th year for employees without a premium increase for the high option HMO and the 10th consecutive year with no increase for the low option HMO plan. This is an incredible accomplishment. It's been a tremendous benefit to our employees. The district completed the health and pharmacy management RFP process last year, and in fact, Diane Howard put almost all of our contracts out to bid. The only thing remaining is our little vision contract that we'll address this year. So she kind of teed it up for me and made it real easy for me to jump into contracts that are fresh, but with vendors that you all recognize. And the board approved a contract with United for another 5 years. And at the school district, just to kind of highlight the premiums that your membership pay, an employee can cover themselves and a full family for $252 per month if they fully participate in and complete the Wellness Rewards program. Now, I'm highlighting here the low option HMO, which is our most popular plan. 40% of our employees carry at least one dependent, a spouse or a child. And we do compare other districts, and in other districts, family coverage can cost, as much as $1,000 or more per month. So this slide is a little bit hard to read up there, which I'm surprised because that's a giant screen. But this just simply lists the types of coverage that you have through, I think, sections 1 through 5 or 1 through 6 of your articles. Just the coverage that we will make available to employees, which include, of course, medical. Now we have our doc clinic. My understanding is that you all were very much behind the inception of that. Dental insurance, vision plan, disability and life, term life, and long-term and short-term disability. We have our employee assistance program. And we have, of course, voluntary benefits through Trustmark, which offers some various plans that are noted, and our special retirement plan, 401A, and health plan opt-out contribution, and that's through BenCor. And then this just highlights the contribution rates. The district's monthly contribution rates are listed, and I've added the full-time employee contribution rates for your reference. District employees do pay competitive rates as compared to other school districts, as I had mentioned. And we haven't seen the increase, and I will tell you that, as you know, I'm new to the district, and I can honestly tell you that in my experience, I've not seen another employer that's been able to hold employee rates for 10 years. I know that in the government space, particularly collective bargaining governments, we do try to hold our rates, but 10 years is very impressive. And I again, I'm not bringing you all sunshine and light, which is really unfortunate because you all have had a phenomenal streak there. The fund balance for the health plan is showing critical signs of decline, and then I'll go further into that in a moment. But I do want you to know that in the past, the revenues collected by the district and the employees for the funding of the plan have been sufficient to cover the cost of claims. So we can just dive on in, I guess. Let's look at this. So this is just a really ugly slide, folks. This was provided by our plan actuary. And so the yellow trend at the top of the graph represents revenue, which includes both employee and district premium contributions to the plan, some other things. Please note that the medical, pharmacy, and administrative costs reflected by the blue, orange, and gray bars began to exceed revenues in plan year 2021. It was flirting with it in plan year 20, but then began to exceed in 2021. Note also the blue line representing the plan year end fund balance, which for plan years 22 through 24 is expected to drop below the green trend line, representing the minimum fund required balance, which is 60 days worth of claims. This is required by the state of Florida for self-insured health plans, and the plan actuary predicts, if no changes are made to the premiums or plan design, that the plan will experience a $51 million loss by the end of plan year 2024, actually putting the fund balance in negative territory. While the district is using ESSER funds to offset some of the projected losses for plan years, for the current plan year and also last plan year, those funds will no longer be available after plan year 2024 and are not sufficient to offset all of the projected losses. If the plan year develops as projected by the actuary, it'll be necessary to pass on an increase to both the district and the employees. Now, we recognize that this particular actuary, though very, very skilled, is conservative. He is conservative. This is a shocking slide, and these numbers are credible because he is credible, but I just want you to know that he's also very conservative because he doesn't want the plan to face a loss, more than is predicted. So this slide drills down into the actual numbers behind the preceding graph. As you can see from the top row, plan income is relatively static, with plan years 22 and 23 being assisted by an infusion of cash from the Elementary and Secondary School Emergency Relief Fund, known to us as ESSER. The rest of the information in the slide shows how quickly the actuary believes the plan will run out of fund balance over a period of a couple years. Please reference the gain-loss row to see the exponential loss in funding projected from plan year 20 to plan year 24, right there in the center of the slide. At the end of plan year 2021, for example, the fund had 127 days worth of funding in reserve and surplus. By the end of the year, the actuary predicts we'll still have, where are we now, 90 days, yes, of funding, which will still exceed the required 60 days. But if the revenues remain static with no plan increases or changes, we'll see that fall to 16 days of funding at the end of plan year 2023, but heading into negative territory at the end of plan year 2024, per the actuary, if his calculations are correct. Now, again, this requires a crystal ball, so we recognize that none of this has happened yet, but it is foreshadowed, if you'll tolerate my English degree. Okay, and so finally, this slide considers some plan change recommendations. So the actuary is actually recommending the imposition of a 23% increase to both the district and employees for plan year 2023. However, at this time, management is hopeful that his numbers are still heavily impacted by the aberration we know to be COVID, and the fact that people may have put off routine screenings and elective one-time surgeries, which all impacted the 2021 plan increase, which is continuing in the early part of plan year 2022. Therefore, as an alternative to negotiating and imposing a plan increase for 2023, which takes effect in January, we're recommending a collaborative approach with the unions to closely monitor fund performance together and implement a few plan changes as noted here. Implementing and following this approach collectively and immediately, we'll be able to monitor performance in real time and know our collective future together in full transparency. So just kind of going through this slide, the health insurance article, they all reference that we will agree to meet 4 times per year. I believe that those meetings might have been impacted by COVID, but I will say also that the language isn't clear about who initiates, who takes the lead on that. So we're, as management, committing to taking the lead on scheduling these meetings as a priority for the purpose of collectively monitoring the performance of the plan year in real time this year. Second, coalition bargaining groups will look with membership to increase wellness program participation. Maryland is sharing that the district is seeing a steady decline in wellness program participation. We all know that early detection is not only easier for the patient who has the earlier detection, but also for the cost of treatment for whatever might be detected. So we'd like your assistance in helping us get membership kind of back engaged in wellness. And then 3, we could collaboratively consider United Healthcare's recommended plan year changes, which include radiology and cardiology, medical necessity, kind of going through a review process. Doctors do tend to prescribe, simply, quite frankly, because we're in South Florida, there's a lot of litigation, failure to diagnose cases and things like that. And our coverage is very rich. And so while those tests are needed, clearly there would be a review process, and United believes that that could save the plan up to 1.7 million annually. And then look at other medical necessity add-on programs. Look to see where our doctors are prescribing things at a higher rate than what is typical, what is the norm, and potentially implement other medical necessity programs. Also, surgical management solutions. So if you're getting a colonoscopy, we steer you away from a hospital, organization that charges hospital rates, and we put you in a freestanding facility that's, of course, reputable and vetted by United. That could save nearly $1 million a year. And then digital physical therapy, which is kind of virtual. It's kind of downloaded. Your doctor comes up with a plan, and then you have rather than going into the office 3 times a week, you have your plan kind of downloaded, and there's a virtual component where you can do your exercises through that modality. And that's kind of a new modality, but it is being rolled out in health plans. United thinks it'll save us some dollars. So these, the estimated value is $3.9 million. Obviously, we're not officially bargaining, but we wanted you to have that as a precursor to the types of conversations that we'll want to have with you when we sit down formally. So that's my presentation, and we welcome your questions and comments.
Thank you for that. I guess a question would be, and you kind of hinted at it, that the projected increases may very well be built on the aberration that's been created, most people believe, from COVID, and like you said, delayed procedures or just increased instances of need for medical care because of COVID. What is the basis, or how can we look at some sort of summary or report, I assume, that was produced to explain those projections? Because if you're able to go back to the slide where it showed the projections,
This one or the
next one.
Yeah, the one with the numbers. Well,
So to be able to explain the belief that we're going to go from 247 to 263 to 280, the idea of going up almost 40 million in 2 years, and that's, a sixth of the current expenditures, like that seems like a pretty hefty hike. If there's a way to explain that to us or show us the basis of those projections, that would be of great value.
And I would also I wouldn't stop there, but it's also between plan year 21 and 22, because plan year 22, we're only into April. And that was our concern when we were speaking with the actuary. There's just a lot of uncertainty at this point, and why we didn't feel comfortable coming to you with an increase in premiums. Because our district, with the help of working with the unions, we've been able to keep our claims down. We've been well below the national trends. The national trends were 6, 7, 8%, and we were at 2 to 3%. So that's why we've been able to not increase premiums for 10 years. And that's why we also wanted to start meeting with you quarterly, so we can actually present the actual claims, comparing them to COVID and then also pre-COVID. Because our goal is we want to go back to where we were below the national trends. So if you look at from 22 to 23 and 23 to 24, he's using a 6.5% increase in claims. And that would align with the national trends. I was at a conference at the Council of Great City Schools Monday and Tuesday of this week, and this was part of the discussion. Where is it going to go? It's hard to look at, like you said, we had a 8% increase from 20 to 21. How is that going to be realized going forward? So our best way, the actuaries are doing the best they can. Our actuary met with not only United Healthcare, but all the large insurance providers in the country. He came up with that we're going to have a slight increase, and he thinks 6.5% is a slight increase. We think that that's significant compared to where we've been in the past. So the best way for us to monitor this, since it is just assumptions, is looking at real data, and that's why we want to meet with you quarterly, so we can look at where the claims actually are, compare them to prior months, like I said, both pre-COVID and also during COVID, to kind of see, are we at a higher rate now because of COVID that we're not going to see a decline? Because in speaking with the actuaries and some of the medical specialists, they don't think that we're going to see a decline. But at some point, we are going to restate, where is that basis going to be? So that's kind of where we're at. So I don't know how much data more we can give you other than, these are the assumptions based on their experience with talking with the medical providers.
Thank you.
Well, one of the other areas I see that, that would be in question would be the revenue, the income. We noticed that there's a decline from 20 to 21, and then a decline from 21 to 22, and then remaining the same across the other. And I guess that's just a projection, but is there a reason as to why we have a decline in income? Is it the number of employees, or
There was actually 1,000 employees that fell off the rolls of the health plan, which was new for the district. As we fill vacant positions, we do expect that to increase. We also saw a shift in employees from the high option to the low option, which, since the low option premiums are less, did create some decrease in the premiums. But that is part of what we're looking at too. There's uncertainty, and so if we monitor on a quarterly basis, we'll be able to see the participation in the plan, how that grows. In addition to just looking at the premium increase, there's also revenue we receive from prescriptions, and the prescription rebate can vary pretty significantly from year to year, so that's something we would be monitoring in these meetings as well.
Okay. In terms of the plan changes, will we be getting data to look at, where and how we can best implement those? You mentioned that, we've, made savings because we've collaborated and made major changes, excuse me, made changes that were significantly financial beneficial. And so will we go through those areas you recommended and look at how we can put those in place without severely limiting benefits or minimizing, benefits to employees?
Yes, this was just a preliminary discussion, and I
Yes,
can
and
let
United, a representative from United will join us at those meetings, and they will be able to speak to, the implementation and that sort of thing from a plan perspective.
So you're also saying that we're going to go back to where we meet with United Healthcare, we get a report on what's happened, each month and how we've, been moving, and so that we have a better feel for kind of what's happening, actual numbers.
Correct, right, because this is all based on assumptions. It's all based on what is the actual impact of COVID going to be, and unfortunately, we don't have any history other than what we have right now.
Right.
And so instead of just going with, what the actuaries are projecting, which, as Ms. Bolton said, our actuary is very conservative, and our district has just always been well below the national trends. So the fact that we're at the national trend increase now, I just don't know if that's going to continue. And we want to be able to see whether we still are getting credit for all those changes that were made in the past, whether those continue. And the only way we can do that is just looking at real data on a monthly basis and comparing it to where it was, like I said, pre-COVID as well as during COVID. Because in speaking with the medical professionals and the actuary, they believe that we're going to be at a new higher level of claims, and that the claims are not actually going to decline, which is what I was anticipating. I was anticipating that we weren't going to back where we were, prior to Plan Year 20, but that at least we'd meet somewhere in the middle, and that's not what they're projecting. And
one of the things that, excuse me, that I think that exists for us, and I don't know if it's a benefit or not, I hope it is, and that is the seriousness of cases and whether the cases take people to the hospital or not. And that seems to be the projection of what these different variants tend to cause, and that is fewer hospital stays and fewer, even deaths as far as that goes. I guess the other thing is we would also maybe look at, and Marilyn will know our position on this with the health rewards, looking at how we can increase member participation. Do we have any idea as to why that participation dropped?
Yeah, Theo, I think, we've looked at, is it time to kind of rebrand? We haven't shaken things up or made any changes. So I think over time, folks have gotten used to either they run into issues with actually completing it in a timely manner. They may get frustrated. And we have made changes over time that we thought would help. So, the most recent was to move it to earnings, to give credit to an employee, even if the spouse didn't do it. So I think we just have to continue, looking for that sweet spot of where people stay engaged. We have, not had physicals back in, and some people get physicals, but they're not getting credit for that necessarily for that type of visit. So we may just need to revisit and look at implementing some changes to kind of shake things up, to re-emphasize. And I hope, we can impart upon you. I don't know what happens, in your sessions and your meetings, if that's a topic that is discussed, if it's talked about, that we collectively are kind of all in this together, and the more we pay attention as individuals to our health, the impact that it can have overall for the plan. So I hope some of that could happen, as well, that we really are partnering to get that message out.
If we could look at, I guess, when people apply, and if they end up not being approved, what were those issues that created a problem there? Was it the physical? Was it the survey? What was the blocking item in preventing them from, being approved?
And over time, we actually have increased with United's help to look at folks who are almost at that point of where they're, can complete the program. And they've pushed out, you're almost there. So we're looking at beefing up and as early as possible to give communications to those who have started. But we do look at, and that's something that we can have United also touch base with you, how many people have done one action, how many people have done two action, the split between employees and the spouses, and the participation in that manner. So we do have data along those lines as well. But I did want to, just kind of get a point of clarification. You wanted to look at, we've worked collaboratively in the past to do some plan changes where we increased an ER, added an ER percentage. We increased the deductible on the high option plan. We also...
Pharmacy.
Yeah, some of the pharmacy things as well. So are you wanting information on that to be included in some of the United, meetings to see the tweaks that we made before? What did we realize from that as well? Are you looking to get that information?
Right. And I guess, we take ownership on part of it in terms of, well, both of us actually have reduced our efforts on reminding about the rewards program and encouraging people to participate and advertising what the requirements are and how easy, you can make it happen and how much you can save. If we, kind of put that back out in front of people again, that would also help us to, build up the membership.
Right, I think it's really the messaging over it, that there is a financial benefit for doing it. And you don't have to pass, because if you don't pass, there are other options in order, and that's the whole purpose of it. It's catching something early so that we can make sure that everybody is healthier, saves the health plan money, and it also saves the employee money on the health premium. So I think it is all around the messaging, not realizing that they actually they're getting dollars back in cents for that. They can have their health benefits for free if it's single coverage.
To your question, I would, if there's a way, because we did, while we haven't increased monthly premiums in some time, we did make those series of changes a good 3 or 4 years ago. I don't remember exactly. And I'd be curious to see if it's able to be quantified in literal dollars that the ER change saved the district X amount by shifting some of the financial burden to the employee, the copay increases, the Walgreens and CVS deal. If I would be interested to see what savings and or additional revenue that's generated. I guess it's mostly savings because it shifts costs to the employee in terms of higher copays in ER, but however we could quantify that to see how effective that was and in millions of dollars, how much that has mitigated some of this.
Yeah, and I think the ask we would want to do is, I'm sure we had some of those types of projections, as they're looking at, as they, have shared that they have some other levers we can pull. So I would think that we'd want to go back and say, what did they kind of project, we might say, and then look at the actual to give you a better sense of, where the projections versus reality kind of comes, so we can, collectively say, well, it's projected this way, but we can kind of, that plus or minus of what reality turns into. And one other thing, I just want to make sure, we've committed to doing quarterly meetings. I heard Theo said monthly with United. Quarterly is probably more in a line.
The statements, I think, are monthly, and we used to, if we emailed, we didn't get them automatically, but if you emailed Diane, said, can we see the latest one?
Okay.
So I think that if the contract says that's what the contract says, and that's probably fine. But yeah, if there's a way to get the monthly,
even if we're not meeting, you'd like to just have the
so
data.
we don't have to wait 3 months to see, and and we'll
Right,
keep
that's what I
it
was talking about, the monthly
I
information.
wanted to clarify what
Monthly
you meant by
information,
that.
Yeah,
Okay.
monthly information, so that we can be better prepared to make good decisions. But the quarterly meeting is what we're doing. I thought that was accepted
Okay.
already. Okay.
One of the things, I bargain on the other side of the state with Pinellas County Schools, which is in a similar boat, obviously a big school district, not quite as big as this one. But I remember the last couple years, there've been some minor plan changes, but I know that the coalition bargaining with the teachers, police, and ourselves with the district has helped us mitigate some of these costs, which I would assume are being contemplated in terms of the pharmacy costs, because that's one of the biggest drivers of this, in terms of your maintenance medications being mail order bulk, as being something that we've pushed heavily, because folks are always going to need, well, not always, hopefully they'll get off of the meds, but for it building into people's sort of routine that rather than going to Publix or CVS every month, you can get a bulk 90-day order and save money for both yourself and the plan at some of these, preferred providers, which I know Publix is kind of the general one that everybody lives close enough to a Publix rather than the other entities. I also am interested in the wellness. I know that during, the COVID year, COVID year and a half, has really sort of changed everyone's routine. I think part of ramping that up into being a back to school reminder wellness helps everybody kind of campaign is something we're contemplating in our other districts we represent employees at. And I think, it sounds like a good idea here. I do want to recognize that as much as I love the fact that smartphones and tablets are the way that best drive this, I do know that many of our bargaining unit personnel don't necessarily have those types of phones that allow for that. So if we wanted to think about at work sites being able to provide a workspace location or computer that everyone can go on, if they don't already have access to that. Like, for example, you could have custodians be able to log into the computer to check out their normal paycheck stuff and health wellness stuff and kind of build it into the routine. And obviously to figure out if the languages offered on the wellness plan, like, for example, we've got Creole speakers, Spanish speakers. I don't know if all the wellness materials are in those additional languages, and if they're not, if we could start to push that in, that'd be helpful.
We do produce the wellness information in English, Spanish, and I believe we've even gone to in some reals Portuguese for the clinic. So although not all of our materials, the reference guide is not, but when it comes to the health rewards program, that is in multiple languages.
Do you have data on the clinic and its utilization and cost versus savings or projected savings and things like that? Is there a way to get an update on how that's gone? Because I don't have the contract language memorized in my head, but I feel like it might have been codified as a 2-year pilot program, maybe. I'm not positive it's permanent. I just want to keep an eye on that to see if it's achieving its desired outcome, and then if not, how to improve its utilization.
Yeah, it's not, well, there's been some operational changes at the clinic. The first operator that we hired did not work out, so last year we swapped that to a new clinic management company, Marathon. They're spending a lot of time doing drug testing, pre-employment drug testing, so we are going to right now we're out for a bid to help to not take away the opportunity if people want to go there for pre-employment drug testing, but to offer decentralized solutions as well. And then we plan to really push the utilization of the clinic. We have, what did you say, Marilyn, 8 schools here, not 8, but 8,000 employees or so. We have a large group of employees that we can target to just let them know you have a clinic, and we really, so the two years are passed. We do have a 5-year contract with Marathon. Obviously it has termination provisions, but we want to give the clinic a little bit more time to really get up and running and to function the way that it needs to, because that really does help to take plan costs away when people are going to the clinic for those visits for screening and things like that.
I have a question. Do the substitute teachers, do they have health benefits? Do they, like a sub?
No.
No.
Maybe if you look into allowing them to buy into at least the clinic, you'll be able to get some more function out of the clinic and maybe generate some revenue and actually give these people some type of a little bit of a medical coverage that we can, just by buying separately into the clinic.
So of course, you know, from a management perspective, every United covered employee that goes to the clinic actually saves money on the United plan, right? Because they're accessing care at the clinic, and so they're not kind of submitting claims through United. So that's our focus, to really impact the cost of the plan through the delivery of the clinic. So if we're adding folks to the clinic that aren't covered under United, it may take those valuable spaces. So that's just my management perspective, speaking to numbers only.
Yeah, but it's my understanding that the clinic is costing you a flat rate no matter what, if somebody uses it or not. So it's just an idea to attract more substitutes that I think you guys also need. If you offer them to buy into the clinic at a cheap price, you can offer them some type of medical benefit, which they don't have just by being a substitute. And you get to use the clinic a little bit more, and you'll be generating some funds from it. So that should help the United Healthcare in this plan, because it's all connected, the funds, right?
So the clinic is managed under a different line item. It's not a United provider per se. Am I saying that right, Marilyn?
Yes.
So if there's a surplus in there, let's say the clinic costs you $4 million for the year, and you made $5 million, it's just, exaggerated numbers. That $1 million wouldn't go into this fund?
Well, there is one fund for health, and the clinic is a line item within the health fund.
Okay, so,
Yeah.
all right. That's just a suggestion, an idea.
No, it's,
Yeah,
yeah,
and
it's
it's-
something
it's-
we can,
yeah.
it's something we can look into to see whether it's a possibility. But it would change the whole management structure of how we originally set it up, so we would just have to go back and look at that. Right, we can go back and look at it.
How is the clinic conveyed and communicated to new employees?
It's part of, we have communications as they're actually signing up and are on the hub where we have all of our benefit information. There's information in the benefits reference guide. But we can always look at, we're looking at right now a communication campaign to where at least the local schools and principals we did that initially when it was initially opened. We invited them to open houses. The staff is ready, at some point to begin to go out. We've talked about even for this building, even to bump utilization in this building, to kind of work with the dietitian and the wellness person to create some healthy lunches and information that they can have a day. Our cafeteria folks here are working, that they're willing to work with recipes and kind of promote in that vein. Taste a meal, here's a recipe, talk to the nutrition folks. It's promoted, cross-promoted if someone calls United. Anytime, we had a vendor summit so that all of our partners know what's available at the district. So those are just some of the ways that it's done.
And so we're looking to increase some of those communications, though, right? So maybe next time we come
Absolutely.
back, we can have some sort of update on how we're going to do
They're
that.
looking at producing magnets or some type of thing, a trifold that can be given. So we are looking to, now that we're getting some stability, and as we look to free up more space for appointments, if not all, new hire screening is done there, then we can actually have more that we can go out and local schools and employees to come in.
But we do have the figures that you requested that we'll be able to share with you to show you how utilization is. But I think we'll all agree that we want that trend line to go up more and really see the benefit of the clinic.
I'm sorry. Just one other question. Do we have like a MRI machine at this clinic or x-rays and stuff like that? Because I know that the county has their own clinic, and the way they were able to save a lot of money in their health and benefits is they bought their own MRI machine, and they go there for their MRI. So that was able to, so we might want to look into maybe getting some better equipment, larger equipment that costs this plan a lot of money, that we can refer straight to the clinic for the MRI or for the X-rays or for the, CAT scan. Just a suggestion.
Yeah, currently, there's no imaging equipment, but they do have resources that when it is needed, that they've looked at to actually, be able to let people know what's available right now in the community.
Theo, do you have something?
Yeah, just a question. Looking at this chart, I see that the ESSER funding for 21 and 22 is listed, and I realize it's to be determined for the next 2 years, but do we have any ideas as relates to a projection as to what those amounts might be or could be, or a range of figures as to what those contributions could be from ESSER?
Well, I can tell you for 2022, I was originally projecting it to be, I believe it was $5 million. But because originally when I made these projections, when I submitted the awards to the Florida Department of Ed, it was prior to having a lot of that information. I expected the COVID claims to gradually decrease each year, and I don't know that that's going to be true, so that's why I have it as to be determined, because I had originally for 2023 only 2.5 million. So I don't expect it to be that low, and that's why I have it as an estimate, that we're just gonna have to wait and see what it is. And projected, originally I had 5 million for 22, we increased that to an estimated 10 million based on where we were in 21.
Okay.
So that's a reason for that. So then any savings that we have within the ESSER funds, we will be able to utilize if there is availability in order to cover any COVID-related health claims, which will help reduce the burden on employees. The only problem is if we don't start to see that to decline gradually each year, eventually it's going to have to be absorbed by both, or passed on to both the district and employees. So that's why that's something to watch to see whether we start to see a decrease in the COVID-related claims. And our United Healthcare can break out the claims to say which ones are COVID-related, because there's a special coding when it is COVID-related. And we can include that in our quarterly meetings.
Do you guys have, and obviously there's different plans, so it varies, but is there like an average revenue per employee that, looking at the total income and how it's listed as static for the next 3 years, or for this year and the next 2 years, is there a way to look at vacancies and say, for every 100 additional employees we bring on, that generates an average of X amount of dollars, to see that if we fill 500 positions or we get back to full staffing, is there a way to better project future income based on increased employment levels?
We can do that. It's still going to be an estimate, because it is going to depend on, is this employee going to be one that has high health claims or low health claims? But we can definitely do an average and just know going into it, it's our best guess.
Okay.
Yeah.
Thank you.
And I guess one of the things that I look at is we had a decrease in employees, more than likely, that kind of helped to decrease the amount of income, but yet the amount of expenses did not decrease. They continually rose.
Mm-hmm.
That's kind of challenging.
Correct.
Yeah, we noticed that
Yeah,
too.
we did notice that too. That was a big part of our conversation. And also the part of the conversation that I had when I was at the Council of Great City Schools, that we're seeing a lot more expensive drugs coming onto the market, and that is expected to have potentially a significant impact on all health plans. And when I say significant costs, multi-million-dollar drugs. And so yes, they can cure, but they're very expensive and they come at a cost. And there are going to be several that are going to be coming on the market. So that's a challenge we face. So it's not just COVID related, but it's also new therapies and the cost of those therapies being very expensive.
To that point, Are we also, and I'm assuming we are, monitoring which drugs that were in that sort of category of being on the higher end of pricing, but yet they're going to go into generic, like basically the patent's going to be changed and going to go into a generic status in the next year or so? Maybe there's somewhat a level of offset that can be accomplished.
Yeah, we can definitely look into that, and United Healthcare can also break it out and look at the high claims so that we can hopefully better estimate what the trends were going to be long-term.
Yeah, and they consistently look for those. I don't know if there's any of those drugs that we all know. You know, it was a big deal when Prozac went to generic, for example, and it saved a lot of money, and now it's hardly at all prescribed, unfortunately, because the providers don't make any money on the back end, but such is the nature of pharmaceuticals.
Are you able, through United Healthcare's, coding or tracking, to kind of, as precisely as possible, pinpoint, for 21, 22, the increases, do they have a ballpark of what is exactly attributed to COVID, like COVID visits or medical, procedures that were a consequence of someone getting COVID and then having a subsequent reaction to COVID that led to a medical procedure? Like, of that 247 million in total expense, do they have some ballpark that, 15 million of that was COVID or 20 million? Is that how we could best understand the increase and a potential leveling off?
We do have that, and that's why we were able to claim it as part of ESSER. And our auditors were able to get a full detail by claim in order to make sure that it was going to be eligible under the federal program. The only issue is when they were going through those claims, if you go in to be treated and if a patient went in to go and be treated and they also had for something and then also had COVID, it could have been coded as a COVID-related expense, even though it wasn't necessarily COVID-related. And so that might be the challenge with it. And I think now, looking in 22, it's going to be more accurate, and looking in later into 21, it will be more accurate. But we do have that information from United Healthcare, and the numbers, I know when we were looking at them, they're staggering.
Yeah. In fact, when someone threw out 15 million, that's about what the COVID costs were in 2021. It's the inpatient costs that are so expensive.
Okay.
And that's kind of what I meant, in that, the inpatient should decrease.
Right. We're hopeful.
We should have a positive impact on our expenses.
Yeah, if we were not, we agree, and that's why with these numbers, typically, we'd be looking at plan year 2023 to seriously have a difficult conversation about potentially increasing rates, but because we agree that, COVID really did kind of throw us a monkey wrench that we weren't expecting, and so instead we're suggesting that we'll monitor monthly and really see if there's a there, so to speak.
All right. Any other questions? So
Yeah, can we get a copy?
Yes.
Yes.
Yes. I'll send it after the meeting.
Thank you.
And then we'll start sending email updates from UHC, right?
Yes.
Okay.
Yes, and then we'll schedule.
Right. So then
Yes.
it's looking to establish begin these quarterly meetings. I don't know if these have happened for years or not, but we see it in the contract that we're supposed
Prior
to
to
meet
COVID,
quarterly.
yeah, we did,
Right.
prior to COVID. Maybe not 4, but we had some that they kept us abreast of what was happening.
Okay. All right. Well, we're looking to establish that and stay on schedule for that going forward. So what we're thinking is that having our first one in early to mid-June, and at that time we'll also start bringing forth some ideas, because between now and then we'll see some trends, right? But we'll bring forward some ideas in consideration for proposals.
Okay, and just note that, sometimes during June, we won't be available because of other activities, but as long as we can talk before the dates are scheduled, we'll be
Right.
good. Okay.
Okay. We'll try to make sure we schedule it where everybody can attend. And if we need to meet virtually, we can also do that as well. I don't know how long you had to drive to get here, but,
I had other stuff here, so.
oh, okay, all right.
You would have seen me email you asking for a virtual option if it was come here for a 2-hour meeting, 8 hours of driving.
All right,
Yeah.
all right.
And, well, the last thing I'd like to say is we would like to begin to act on our improving our rewards program participants, that kind of thing, as soon as we can, get something together to move on that, so that we have full advantage, because time, does get tight, because we have to, generally the open enrollment ends in early November or late October, something like that.
November.
So we kind of have to back it up and see how we can best prepare.
Right. So as we start making any progress towards that of communications or any marketing plan, we'll be sure to share that with everybody.
How's the nav,
Also,
Well,
they
I was
have
going to say for the healthy rewards, it's really June 30th.
how's the navigation with that website for those? I haven't used it in years personally. I don't have the medical benefits from here, but I helped one of my custodians at my school, and we were looking for the form. He was going to the clinic for his blood work, and I couldn't find the form, no matter how hard I looked for it. Eventually, he called somebody, and they directed him how to find it, to print it out. But I found it very difficult to navigate that website. So is that maybe an issue also, or is it just I haven't seen it in years?
I think the misconception is that we have our information about the program on the district's website, and everything else is housed in United. So the actual form to take to your doctor, it's not on our website because they're personalized. So all of those things, but it might be helpful, and I'd look for guidance from you all. What are the best ways? How do you actually communicate with your membership? What can we give you as a tool? Because, we do many things. We do videos, we do documents on the website, we have, our teams are talking on the phone and sending email links, but we don't know specifically what tools you all use. So if we can craft something that you have found to work with your populations, we'd want to do that. So if it's a cheat sheet to say, where do I find X? Give me some guidance on what would help you to promote the program, and we'll put it together.
We've had some positive things that happened as a result of COVID that helps us to be in touch with our members, and I think we can, probably put some of those in play to try and help with that. But I just want to go back to something you said about, I was talking about open enrollment in November, but as far as the health rewards, isn't the deadline date still the 31st of August, or has that changed?
I thought it was.
It is 31st of August, is
It
that
is.
right?
It is for full credit, 31st of
Okay.
August, and then December 31st for a partial.
All right, I apologize. It used to be June 30th.
Yeah, I just wanted to be sure because June 30th is around the corner, and that doesn't fare well with us.
I apologize.
That's all right, no problem at all.
But if they could be done by June 30th, that would be great.
It would be. Thank you. Okay, all right. Thank you.
All right. All right, well, thank you for making that presentation and sharing all this information, and thank you all for being here today. I'll look at the calendar to see when we can maybe schedule our next session, and in the meantime, we'll be sharing the information we discussed today. All right?
Thank you all.
All right, everybody. Have a nice day.
Thank you.
Again.